Hi, and welcome to the first part of ASPMN's Pain Management Certification Preparation course. The mission of ASPMN is to advance and promote optimal nursing care for people affected by pain by promoting the best nursing practices for both registered nurses and nurse practitioners. ASPMN, with the American Nurses Credentialing Center, offered the first national certification in pain management nursing back in 2005. ASPMN also publishes core curriculum for pain management nursing, which the third edition is available now, and we are currently working on the fourth edition, and supplemental publications that constitute the framework for specialty practice, but does not assist with test development. ASPMN membership benefits include enjoying ASPMN's listserv, where you can post your pain management questions for fellow members to answer, and you do receive responses from pain management specialists from across the country and even outside of the United States. We also keep abreast of legislative issues, both nationally and locally. We have a wonderful legislative team. We talk about state advocacy and federal government affairs as well. With membership, you also receive a subscription to Pain Management Nursing, which is a peer-reviewed publication on pain management in clinical practice, advocacy, education, administration, and research. Wonderful magazine. Additionally, members receive research grant opportunities. We also receive discounts on books and courses, ANCC certification exam fee discounts, numerous continuous education courses, and discounts on national conference registration. We also have networking opportunities with colleagues across the country who share your passion for pain. It is very easy to join ASPMN. You can log on to the website at aspmn.org. And remember, every nurse is a pain management nurse. ASPMN, besides certification preparation course, offers geriatric pain management as well, advanced pharmacology, and fundamentals of pain management. At this point, I would like to say conflict of interest disclosure for this course for both myself and my colleague, Maureen Cooney. We have none to declare. At this point, I'd like to introduce myself. My name is Mary Milano Carter. I am in New York. I am a nurse practitioner, and I've been working with chronic pain patients since 1998. I'm also board certified in pain management as well as gerontology. I was the founding president of the Long Island chapter of ASPMN, and I've served on the National Board of Directors as well as chair of the National Master Faculty, currently serving as Master Faculty. I am also a member of the New York State Pain Society. I'm an adjunct professor at Long Island University, teaching in their master's and FNP program. I am Reiki certified and do practice Reiki with pain patients. I'm also a certified prescriber of medicinal cannabis, and I serve on the editorial advisory board for Pain Medicine News, NP-PA edition. Maureen?
Hi, so I'm Maureen Cooney, and you will figure it out that I am also from New York, so you might as well know it now. You're going to listen to two New Yorkers for the next hour or so. I'm a pain management nurse practitioner in an academic medical center. I've been a member of ASPMN since 2004. I've been doing pain management since 2002. I've been in the New York City ASPMN chapter and on their board of directors, and I've been on national ASPMN's board of directors since 2014. I've served as treasurer, and I'm currently the president of ASPMN for the years 2020 through 2022. I'm board certified in pain management, and I'm an advanced practice pain management nurse. I'm also board certified in hospice and palliative care nursing. And I serve as the adjunct faculty at Pace University in their family nurse practitioner program. You can take it from there, Mary.
Thank you, Maureen. So just to talk briefly about the exam, there is 150 questions, 125 are scored, and 25 are questions that are not scored. They are test questions. And the breakdown of, you have 3 hours to complete the test. And I'm sorry, I don't know why that advanced. You do have 3 hours to complete the test, and areas will include fundamentals of pain, including the science of pain and assessment of pain, will be approximately 42% of the exam. Interventions, including plan of care, treatments, pharmacology, and non-pharmacological treatments, are about 42% of the exam. And professional practice, including education, advocacy, ethics, and regulatory principles, are 15% of the exam. On this slide, this is certification test preparation materials. So there are different websites here that you could tap into for study aids, references, as well as the core curriculum and study guide. So we're going to proceed with the first part of this certification preparation course, which is the science of pain. So we always start with, what is pain? So the International Association for the Study of Pain says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describe such damage. The definition of pain that we love the most by Margot McCaffrey back in 1968, when she started studying pain, is whatever the experiencing person says it is, existing whenever the person says it does. To get into some major theories of pain, there are quite a few. These are some of the major ones, and we'll get into each of these. The biopsychosocial theory of pain states that pain is a totally emotional experience, that it's an illness that is not cured, but managed, and it focuses on the diversity and differences of all patients and what they are experiencing with pain. The specificity theory states the opposite, that pain is a very physical experience for the patient. It is actually the first modern theory of pain, and if you can believe, it was stated by von Frey in 1895, that specific pain receptors transmit signals to a pain center in the brain. Pattern theory accounts for abnormal pain. So this theory states that nerves detect pain, but also detect other sensations as well, that there are no specific nerve fibers in the body. The gate control theory was stated by Melzack and Wall back in 1965, and states that pain is controlled by a neural gating mechanism in the brain. The gates in the nerve fibers between the peripheral nervous system and the central nervous system actually controls how pain flows and how pain is stopped. The multidimensional model is a signal of impending actual tissue damage, only activated in the presence of stimuli. So let's get into a few of these theories of pain. The biopsychosocial theory of pain, examples of social theory that affect pain are things like a punishment for wrongdoing, or an emotional state opposite of pleasure. Pain perception is a psychological process. It's shaped by our thoughts and emotions, also shaped by our different cultures and what is normal to different people. And we do have a set of learned behaviors and motivations that will affect our pain experience. Thought patterns also affect pain perception, and it's dampened by optimism, realistic appraisal, distraction, self-efficacy, and can be amplified by cognitive distortions like catastrophizing or being helpless. Emotions that affect pain perception, like fear, anxiety, anger, depression, or severe or prolonged stress, will actually feed into pain and make the experience a little bit worse for the patient. The specificity theory of pain is very straightforward. It talks about specific stimuli affecting the patient or person, and then specific physical and chemical responses occur. These chemical responses then travel along specific nerve pathways to the brain. The pattern theory of pain emphasizes stimuli intensity and central summation. Perception is formed by the sum of internal, environmental, and psychosocial stimuli around the patient or person. And this accounts, like I said before, for abnormal pain states, things like phantom limb syndrome. Advanced goes to the neuromatrix theory, which pain is an individual multidimensional experience shaped by a unique structure and function of each nervous system in the context of that sociocultural context. So everybody is different in their experience here. The gate control theory of pain is definitely the most widely accepted theory of pain. This is Melzack and Wall, 1965. Here, the focus is on central nervous system modulation of pain. So transmission can be facilitated or blocked in the dorsal horn of the spinal cord, the backside of the spinal cord. There is an ascending track of the spinal cord up from raising painful peripheral stimuli up from the periphery, and there's a descending track from the brain, which includes thoughts, feelings, and motivations to help stop the pain. This actually, the gate control theory of pain, led to many, many discoveries and many treatments for pain. The first and biggest discovery was the discovery of the endogenous or within us opioid systems back in the early 1970s. This includes things like beta endorphins, enkephalins, and dynorphins. We'd also discovered descending inhibitory systems, and new therapies emerged from this. Things like epidural steroid injections, and even the use of external TENS units for muscle spasm. They all work on the gate control theory of pain, trying to help the descending tracks close the gates and stop the pain. To get a little more into the gate control theory of pain, you can have an open gate or a closed gate. When you have a closed gate, there is more activity in the large diameter fibers. These are your A beta fibers. When you have an open gate, there is more activity in small diameter fibers, and this includes both A delta fibers and C fibers. So A beta fibers are the good guys. They help close the gate. The A delta fibers and the C fibers open the gate and transmit pain. And there are differences between A delta and C fibers. So A delta fibers are known for their first pain. These are very thinly myelinated nerve fibers that are large in diameter, have very quick conduction of pain, and it's typically that sharp, localized, the patient knows exactly where it is pain. The C fibers, on the other hand, are a little bit different. They are unmyelinated. They are thinner in diameter, and they have slow transmission of pain. So typically transmitting dull, aching, visceral pain that is very diffuse, not localized at all. The multidimensional model of pain is basically a framework for the entire biopsychosocial experience of each person with pain. It includes physical and emotional responses, as well as social and cultural. And if you look at this model, it's nociception, which we will get into. So the nociception of pain, the pain itself that the patient has experienced, which leads to suffering and then leads to pain behaviors, specific pain behaviors of the patient. Now we're going to get into the pain and physiology and pathophysiology. And we're going to talk about nociception. So nociception is the term about how painful messages from the periphery convert into a stimuli, travel along the nerves through the periphery up to the dorsal horn of the spinal cord to get into the ascending tract, come up to the brain, and how the brain responds. So nociception includes 4 distinct steps. It's transduction, transmission, perception, and modulation. So first we're going to talk about the first step, which is transduction. So with transduction, we're basically talking about a transfer of energy from one form to another. So some type of energy that has affected the person, something chemical, mechanical, or thermal, has affected the patient and is creating a transfer of that energy that's harming the patient into a stimulus that's going to travel along the nerve. So Suprathreshold stimuli produces action potentials, and this impulse travels along the length of the axon, releasing ions and neurotransmitters that facilitate signal transmission along the way.
So Mary, before you go any further,
Sure, Maureen.
what kind of, I know you said chemical, mechanical, and thermal stimuli, but there are mediators. What are these mediators?
Correct. So when an injury happens to a patient or a person, chemical, mechanical, thermal, what happens is this chemical, mechanical, or thermal stimulus will create a substance release in the body to create a inflammatory response, inflammatory mediators. These are messengers that promote inflammatory response in the body and help that pain signal travel. So these inflammatory response mediators are things that we've all heard of before, like proteins and peptides, glycoproteins, prostaglandins, leukotrienes, nitric oxide, and even oxygen-free radicals. So the big one that probably people hear about most now are cytokines. Everybody talked about cytokine storm with COVID. Cytokines are actually inflammatory response mediators that will promote the inflammatory response and help the pain signal move along that axon. Really good question, Maureen. So that's transduction. We're going to move to the second part now, which is transmission, which is basically moving the message. So out in the periphery, the skin or the joints, you've had a noxious stimuli, and it's turned into a stimuli that's going to come along the nervous system. And this is transmission. It's moving the message. So the afferent nerve fibers here, which are your A delta and your C fibers, which we did talk about. So the ones that carry pain signals, remember the A deltas are the thinly myelinated, large, quick transmission. The C fibers are the unmyelinated, thinner, and very slowly transmitting fibers. They both take part in bringing that noxious stimuli along the peripheral nervous system up into the dorsal horn of the spinal cord, which is the back of the spinal cord. Here, the signal will jump into the dorsal horn, come up the ascending track to the brain where perception happens. So the impulses are transmitted via the spinal thalamic tract to the brain, into the brainstem and the synapse in the thalamus and the medulla. So here is conscious realization that pain is present, and your thalamus actually allows perception into the brain. The cerebral cortex receives the pain signal, and the signals are then sent to a variety of areas in the brain's somatosensory cortex. This includes the hypothalamus, which gives the patient the emotional response to pain, the limbic system, which actually gives the patient goal-directed behavior on what to do when they're in pain, and the reticular formation, which gives the patient the emotive response to the pain signal. So this pain is received by the individual, and its physical and psychological influences occur prior to pain becoming part of consciousness. So when the brain realizes, wow, it's perceiving, I'm in pain, my finger is on a hot stove, then modulation occurs. This is the fourth phase of nociception. So modulation is basically inhibiting the pain impulses. So the descending signals, the descending track of the spinal cord, the neurotransmitters block or partially block transmission of pain impulses to mitigate or end the pain. These include things like endogenous opioids, which I mentioned before. Serotonin and norepinephrine are the reuptake of these two are inhibited, of these neurotransmitters, and these can actually stop the nociceptive impulse from jumping onto the next neuron and continuing the pain. Also things like gamma aminobutyric acid, acetylcholine, and oxytocin are also released here. So lots of things that the body can do to help inhibit its own pain. And now, Maureen, I will turn this over to you.
Okay, Mary, I'll take it from here, but before we get into the next discussion, I just wanted to ask you, how important is it for people who are planning to take this certification exam to know about those nociceptive processes?
They are very important, and very important to understand as a pain management nurse or nurse practitioner, to understand how pain is created and travels through the body and how the body responds in those 4 distinct phases. It's important to know because you need to know the pathophysiology of pain, but also where different medications would work along each of those pathways. So very important to know that, and very important to understand the gate control theory, which did lead to a lot of our current treatments that we have for pain.
Great. Thank you. That's really helpful.
You're
Okay, so I'm
welcome.
going to talk a bit about the physiological categories of pain, just kind of getting practical about what is it that we're seeing with our patients. So pain is generally categorized by either being nociceptive or neuropathic pain. I like to think of nociceptive pain as normal pain. It's the kind of pain that we expect to get when we have predictable damage to tissues or organs. Nociceptive pain is categorized by either being somatic or visceral. And as somatic indicates, somatic pain is pain that's arising from the peripheral tissue, the superficial tissue, the soft tissue, the connective tissue, the muscles, some of the deeper muscular layers. That will give rise to what we call somatic pain. And somatic pain typically is felt as being sharp or pinching, dull, or even cramping in sensation or aching in sensation. So when you're assessing your patient, that's one of the reasons that you want to ask what the pain feels like. What are the qualities of pain? Because you want to get at what type of nociceptive pain your patient might be having. Versus visceral pain. Visceral pain is coming from damage to the viscera, to the organs in the body. So somatic pain, you can usually localize very well. If somebody has a fracture, they'll be able to point to where that fracture hurts, whereas visceral pain is often poorly localized. It's coming from the organ. So when you think about appendicitis usually starts out in the middle of the abdomen around the umbilicus and then eventually localizes, but initially it's generalized, difficult to localize. Same thing with cholecystitis, kind of difficult to localize until it gets very, very much further on down the process. So visceral pain, often poorly localized, described as deep, aching, or sharp and stabbing types of sensations. So those are the words that you're looking for. Visceral pain is also often accompanied by nausea, by vomiting. On the other hand, then we have neuropathic pain. Neuropathic pain, I like to think of as being abnormal pain. It occurs as a result of structural damage to the nerves themselves, either in the periphery or in the central nervous system, and it results in dysfunction within the central nervous system. Neuropathic pain can be localized. It can occur along a radicular pattern, meaning that it's following the pattern that a nerve is traveling. So for example, people who will tell you that they have sciatica can take 2 fingers and draw from their lower back, from their lumbar region, across their buttock and down their leg, drawing the pattern that that pain is traveling. That would be radicular type of pain. So it would be very localized. It often follows a dermatome, and that would be your radicular pain, or it can be regional. So in conditions like diabetic neuropathy, the pain may occur in the toes, the foot, and the toes, the foot, the ankle, even up into the lower leg, and we'll call it like a stocking or even glove distribution. So that's more of a regional kind of description of pain. The words that you hear when someone has neuropathic pain is that the pain is burning, it can be tingling, it can feel like pins and needles, it can feel like sharp, cold daggers stabbing at them. You'll even hear people describe their neuropathic pain as a sensation that there are little tiny red ants crawling underneath their skin. It can occur spontaneously in an intermittent fashion, or it can be more continuous. The spontaneous and intermittent tends to happen more with peripheral neuropathy versus the continuous pain tends to happen more with neuropathic type pain related to a lesion in the brain or in the spinal cord. And as you see here on the slide, When it comes to central pain, meaning from the brain or the spinal cord, there are a couple of different types that we talk about. There is sympathetically maintained pain, and with sympathetically maintained pain, it's coming from the sympathetic nervous system, abnormal activity in the central nervous system that results in all kinds of changes, dysregulation of the sympathetic nervous system, so that you can actually see modeling of the skin, abnormal temperature changes of the skin, abnormal sweating, and edema. And another type then is deafferentation pain, which comes from the central nervous system. A type of deafferentation pain is pain that comes from from an amputation, where you hear about phantom limb pain. So actually that body part isn't there, and you would expect that there wouldn't be any sensitivity, but with deafferentation pain, because there is destruction of the nerve tissue, you get this abnormal pain signal continuing up through the central nervous system to the brain. And then what's probably more familiar to you is the peripheral type of neuropathic pain, where you can have mononeuropathy involving one nerve, as I was talking about sciatica, or you can have polyneuropathy involving many nerves. They may be tiny nerves or they may be larger nerves, but an example of polyneuropathy would be diabetic neuropathy. But just to talk about neuropathic a little bit more, because it's probably the one that's a little more complex or less known to you, remember that it's abnormal processing of impulses either in the periphery or in the central nervous system. And even peripheral neuropathic pain can go on to lead to central nervous system if it ends up becoming chronic. It's caused by a body sensing lesion in the nervous system or a disease. So somatosensory is body sensing nervous system lesion or disease. And it can be confirmed diagnostically by seeing a lesion or disease, as one would see with stroke on an MRI, or with vasculitis when they would do a biopsy, or with diabetes. And there is evidence of this nerve lesion, such as reduced or increased. So either a decrease or an increase in the sensitivity, altered sensation, or a change in the pain response, even to light touch. So you'll be hearing about this throughout the course, but in terms of touch, normally light touch is not painful, but people with neuropathic pain, especially central neuropathic pain, you might touch an area of their body very lightly, but that could be perceived as very painful. Or something that is painful, but what would normally be mildly painful is experienced as very, very painful in someone who has neuropathic type pain, especially involving the central nervous system. So looking at nociceptive and neuropathic pain, as all things in life, there's an awful lot of gray area. Many pains are not specifically one or the other. Oftentimes we have a mixed type of pain. But for example, nociceptive pain of and by itself, an example of it might be postoperative pain, could be postoperative pain. Mechanical low back pain, where you have bone against bone osteoarthritis in the spine, that might give you mechanical low back pain. Sickle cell crisis might involve nociceptive type pain if all you're doing is involving blood flow, say, to an area of the bone. It would be a nociceptive type pain. Osteoarthritis, and you're talking about joint and you're talking about bone versus bone, it might be nociceptive pain. And some of our sports and exercise injuries are nociceptive pain. If you fracture an arm, that's nociceptive pain. Versus neuropathic pain. Pure neuropathic pain is what we get with post-herpetic neuralgia. That's what you would see after shingles, where pain persists in the area where that distribution of the neuralgia was. CRPS is chronic regional pain syndrome. It's a central type of pain involving the sympathetic nervous system. Trigeminal neuralgia involving the nerve, the trigeminal nerve in the face. Patient gets pain, neuropathic type pain across that trigeminal distribution. Distal polyneuropathies, again, diabetes, diabetic neuropathy, and neuropathic low back pain occurs when you get irritation, compression of some of those spinal nerves coming out through the bones in the back. As those nerves come out, there may be calcifications, there may be narrowing, leading to neuropathic low back pain. But examples of mixed type pain would include cancer pain, low back pain, because as you can imagine with low back pain, it's often mechanical, the bones, as well as the nerves that are coming out through those bones, through the vertebral bodies. And then ischemic pain would be an example of a mixed type pain.
Hey, Maureen, I have a question.
Yeah.
How can something like cancer pain be mixed, both nociceptive and neuropathic?
So good question. And it can make cancer pain very challenging to treat. So I'll give you an example, pancreatic cancer. With pancreatic cancer, you have this cancer invading the organ. So you're going to get the visceral component of pain, which would be a type of nociceptive pain. But as that tumor invades the surrounding nervous structures, so you have the celiac plexus, which is one of the sympathetic nerve bundles, which lies very close to the pancreas. So that pancreatic tumor will then invade that celiac bundle of nerves and the related nerves coming out of there. So you'll also have that neuropathic component. And it makes it very challenging because now we need to focus our treatment on both nociceptive pain as well as neuropathic pain.
Wow.
Good question, Mary. Not easy
Thanks,
to
Maureen.
treat.
Thanks for clearing that up.
Sure. So we also categorize pain by the duration of pain, the timing and the duration of pain. Pain can be acute, and acute pain occurs as a result of an acute sudden injury, in which case acute pain is usually short-lasting, recent in onset. Acute pain is a warning that your tissue is about to be damaged or has been damaged, and it causes you then to reduce your activity to avoid doing any further damage. It causes you to want to protect the body part that has been damaged. That's the function of acute pain, and it should abate or resolve as the tissue is healing. So acute pain is very common after surgery. That's one of the big things that Americans don't do really well after surgery is rest. But that acute pain following that tissue damage from the incision is a signal that, hey, you ought to take it a little bit easy here. It doesn't mean it's time to get back out there in the gym and try to burn off all your calories in a half hour. On the other hand, we have persistent pain, which is also known as chronic pain. And we use those terms pretty much intermingled. So persistent or chronic pain lasts longer. The signals can remain active for months or years after the source of pain is gone. So once that tissue heals, that pain should be gone. If it isn't gone beyond that point of healing of that initial injury, then that becomes persistent or chronic pain. And unfortunately, for many patients, that pain is lifelong. Then you can have persistent pain with acute pain episodes. So a good example of that is I see a number of patients with sickle cell disease. And patients with sickle cell disease have sickling all the time. And they will often tell me that they feel persistent pain. And the pain is usually like an ischemic type of pain, but it's a lower level. They can function with it. They kind of put it to the background in their brains to as much of an extent as they possibly can. But when their sickling increases and there's marked increase in the ischemia, they will have an acute exacerbation of that pain. So they have a chronic or persistent pain with an acute exacerbation. And then we have breakthrough pain. Breakthrough pain is pain that occurs intermittently on top of perhaps well-controlled pain or even an absence of pain. Pain may have been very well controlled, but then all of a sudden, an acute episode of pain occurs. It can be idiopathic. We don't know why it happens, but it just happens on top of a background of well-controlled pain. Or it can be because there was a sudden incident, or it can be due to an end of dose failure. So I'm going to give you some examples here. So you may cancer pain is very often associated with breakthrough pain. So a patient may have very well controlled cancer pain, but with cancer pain, patients will have these intermittent idiopathic. We don't know why it happens, but suddenly they'll get a very severe exacerbation of their pain. So that would be cancer breakthrough pain. Or you may have someone whose pain is well controlled on whatever regime they're on, but they decide to go out and golf for the first time that season. Well, now their back pain, which had been well controlled, is exacerbated. That would be incident pain. And then an example of end of dose failure would be somebody who is receiving medications every 4 hours, and that medication is keeping their pain very well controlled. If at some point that that medication no longer lasts the full 4 hours, the full duration of what they were being treated with, then that pain will break through, for example, at 3 hours or 3.5 hours, and require a reassessment of what kind of medication regime they're on. So now we bring up the topic of suffering. And this is one of, I find, the most difficult issues that I have in working with patients in end-of-life settings or in settings in which they are faced with very serious illness. Mary mentioned the biopsychosocial model of pain, and suffering very much plays into this. It is neither nociceptive nor neuropathic. It is a state of severe anguish or distress associated with an actual event or a perceived threat. So there we're bringing in the biopsychosocial piece of it along with the pain, the nociceptive or the neuropathic or mixed type pain. It's a subjective secondary response, whereas pain is a primary response to tissue damage or nerve damage. So suffering requires that you really, as do all things, that you really consider the entire person when you're doing your assessment. So I often give the example of the patient that comes out of the OR after having had an exploratory lap. So they come out and they will have severe, maybe post-operative pain until you get that pain well controlled with medications, but that patient may continue to have a lot of distress and have anguish because the reason for that surgery might have been to go in to stage a tumor. And that person may be dealing with the anguish and the fear and the distress that goes along with this diagnosis. Another example that I would give you of suffering would be the person who has had pain. They may have nociceptive or neuropathic type pain, but whatever has caused that pain has now significantly affected their ability to earn a living, their ability to care for themselves and their family. How are they going to get around? How are they going to pay the bills? How are they going to move forward? Are they going to lose their job? So as you can see, there are many different psychosocial elements and as well as the underlying nociceptive and neuropathic process that goes into the experience of suffering. So the tenets of suffering are very often characterized by loss of control, by loss. So it's loss of control, giving a sense of insecurity, loss of many different aspects of one's life. Suffering is extremely and intensely personal. And that's why it's so important to assess your patient as a whole being, a biopsychosocial being, rather than assessing pain as simply a number on a scale of 0 to 10. It's accompanied by a range of emotions. It is often linked to the sense of one's own mortality. It involves meaning seeking. What is this all about? Why me? And all of those stages of seeking meaning, and often all of the stages of grief. It's associated with separation from the world. One's world becomes oneself, and that is it, that until that person can work through some of these challenges. Often accompanied by spiritual distress, which is why it's so important to address the spiritual component of suffering and assist the person to get some resources and help with this issue. It's associated with pain, and it occurs when one feels voiceless. No easy treatment for suffering. And when I am assessing a patient and I ask them how their pain is and they tell me that they're suffering, it like sends off bells and whistles in my head that I really need to take this assessment to a different level, to really deepen it, to determine how I can help this person to find out what's going on and give them some resources to help along the way here. So the strategies that we're going to be using, as we'll be talking about throughout this course, are based on the type of pain that a patient is having. If a patient is having acute and transient pain, our strategies are going to be really trying to reduce that pain. If the pain is acute, it usually is nociceptive in nature most of the time. So it would be realistic to use strategies that are going to be able to reduce the pain to 50% or more. Many of you may be working in hospital settings, and some of you are working in surgical settings, and you may be familiar with what we call ERAS protocols. ERAS is enhanced recovery after surgery type protocols. And what they've really encouraged is the use of preemptive strategies, basically to treat pain before it even occurs, get things on board before surgery, preemptively manage pain. If we know a patient is going to have pain from a procedure, we can start by giving them acetaminophen, we can give them NSAIDs, we might be giving them gabapentin, we might be putting in we might be doing nerve blocks or putting in nerve catheters to treat the pain before the pain really becomes problematic. That we can do with acute, and it's often transient pain. The focus has a functional focus, but the big thing is that we're going to be able to really help reduce this pain. Compared to persistent pain, with persistent pain, the real challenge, as Mary certainly can tell you, having worked in chronic pain for as many years as she has, is that we really need to get away from the pain score. We need to de-emphasize the score. We need to de-emphasize focusing on the pain. If we can get a reduction in pain by 30%, we consider that a win. But the real win comes from the improvements in function and the improvements in the ability of that patient to cope with life despite the pain that's there. So our strategies in dealing with this are going to be very different, and you'll be hearing more about that later on in the program, but we're going to be working more and more on some of those psychosocial kinds of strategies and cognitive strategies. And then with persistent pain, we know that our goal is to really assist that patient to have emotional stability, to be able to cope with the pain and enhance their quality of life. And then finally, your focus really changes when you're dealing with pain at the end of life. And I have to tell you, one of the most important things to do is to have the conversation with the patient about what their goals of care are. Far too often, I see in the work that I do that when someone has made themselves a DNR and the family has decided and the patient has decided not to go any further with aggressive treatment, that now we are going to move toward care, not cure. At that point, I often hear people say, isn't it time for us to hang a drip of morphine, for example? The answer to that is only if that's what that patient wants. That's what that patient's goal of care is. So when having the conversation, the question becomes, what is the most important thing to you? We can treat your pain to the point that you have no real awareness of having any pain. But the payoff, the price to pay for that is that you may not be able to have a conversation with your family. You may be quite sedated in the medications that we would be giving you at the end of life. Versus if your goal is to be able to be cognizant of what's going on and be able to talk as much as you can with your family and be able to relate as much as you can, then we may be using other kinds of medications or strategies. Or the patient may prefer to have a little more pain, but yet have a little more conversation and interaction. So goal of care is really important, but we have the ability to make a patient very, very, very comfortable and should make them as comfortable as possible at the end of life. So consequences of unrelieved pain. I can remember when I started in pain management nursing, that this was one of the big battles that I had to fight, because there were those who believed that there were no consequences to unrelieved pain, and that basically pain was functional, and if there was no pain, there was no gain. Fortunately, we have moved away from those kinds of beliefs much since 2000, when the Joint Commission Pain Standards came out. But we've done a lot of research, and we know that there are consequences to unrelieved pain. So just looking through this step chart here, this algorithm, with acute tissue injury, the response is going to be the release of those inflammatory mediators, as Mary spoke about. Those inflammatory mediators will occur peripherally, will get that nerve all fired up to have transduction and transmission to the spinal cord. And at the level of the dorsal root ganglion in the spinal cord, you're going to start sending those impulses right on up the spinal cord to the brain, which with repeated painful impulses coming from that periphery, the peripheral nerves get sensitized and they wind up, meaning that when they get stimulated, they will have higher than a normal response to a painful stimulus. With continued sensitization coming from the periphery, The central nervous system is also going to get fired up. The A delta, the C fibers are going to die. The ability to inhibit those painful impulses from going up the central nervous system is going to be lost. And you're going to get activation of nociceptors that are normally silent. So those painful nociceptors, those nerve endings that respond to impulse, are going to get fired up. This will all lead to changes in the central nervous system, resulting in remodeling, leading to the potential for long-term chronic or persistent pain, which is pathological in nature. And as you see here, acute pain is milliseconds, but we're talking about a course that can go on from just minutes all the way through years, depending on how long pain is unrelieved. So the pathological effects as far as the system approach are many. On the cardiovascular system, the effects are related to the driving of that sympathetic nervous system. Pain causes sympathetic activity, which will lead to hypertension. With hypertension and tachycardia from the central nervous system, patients who have an underlying coronary artery disease, for example, may go on to have an MI, they may go on to stroke, go on to develop CHF, and they will have a hypercoagulable state with unrelieved pain, leading them to the risk for thromboembolism. Pulmonary effects are atelectasis and pneumonia. If you have pain, you are not going to be taking normal breaths. Your breathing is going to be more rapid and more shallow, leading you prone to atelectasis and pneumonia. The endocrine system will respond to inadequate pain control, as will your immune response. So patients will have hyperglycemia and will have negative nitrogen balance. On the genitourinary system, when you are stressed, that stress response, sympathetic nervous system response, will result in the renal retention of sodium and water. So you will have edema as well. The sympathetic nervous system turns on for that fight or flight response, and therefore it turns off the motility in your GI tract. So constipation is very common, decreased GI motility, paralytic ileus. This is one of the battles I fight oftentimes postoperatively, is that I will have people say that they don't want a patient to receive an opioid because they don't want to reduce their GI motility. And then I have to turn around and say, well, you know what? Pain that's not controlled is going to reduce their GI motility as well. So let's control their pain, and we can always give them something to maintain their good bowel function. And then there's the psychological impact of pain. The anxiety. I'm afraid to get up and work with physical therapy because it's going to hurt more. I don't want to get up and try to take care of myself because it's going to hurt more. What if I get up and I can't get back into bed because I'm going to be in so much pain? There can be PTSD from uncontrolled pain, just recalling that experience. I had a guy the other day actually who came into the office who recalled a really bad traumatic injury resulting in pain as we were talking about it, and he actually felt as though he was going to pass out. Just from, he remembered looking at his hand and the injury and felt a vasovagal type of a response coming on. So very traumatic. Uncontrolled pain can lead to depression. When will this ever get better? Can lead to cognitive impairments. The only thing that one can focus on is their pain. And it certainly can lead to impaired sleep. And we all know as nurses what impaired sleep is like and how it can impair every other aspect of your life. Persistent pain with modulation processes are all the things I've already gone over. The peripheral sensitization, those peripheral nerves firing, and they become abnormally sensitized. The wind up, so that they respond to not even painful stimulus, but they respond to any kind of stimulus as being perceived as pain. And then in the central nervous system, the same processes occur, resulting in changes in the structure of pain pathways in the spinal cord and the brain. So here are more in terms of, or to summarize, the complications and costs of uncontrolled pain. Pain will lead to poor sleep and will lead to emotional distress. It has physiological effects on the sympathetic nervous system, leading to cardiovascular stress, CVTs and pulmonary emboli, atelectasis and pneumonia, and catabolism and immunological suppression. We know that uncontrolled pain, especially for one that is hospitalized, will lead to a longer length of stay, may actually prevent them from getting out of the ICU because they can't participate in good deep breathing, pulmonary hygiene, can't participate in physical therapy, leading to prolonged hospitalizations, delayed in rehabilitation. And we know that uncontrolled pain eventually can go on to become chronic, and uncontrolled pain in acute care setting leads to dissatisfaction with care. Uncontrolled pain after discharge leads to readmissions and leads to other complications. So as you see here, this is going back and forth. When somebody's staying in the hospital longer, they have greater risk of opioid-related adverse drug events. They also have more risk of other complications such as infection, leading to higher costs all the way around. Chronic pain costs more money on our healthcare system because now we have delays and everything. And dissatisfaction, readmissions, and complications lead to lower payment rates because I'm sure many of you are familiar with the incentives to get patients out of the hospital as quickly as possible. But if they come back in within certain periods of time, we don't get paid for that readmission and we lose money with complications. So persistent pain affects 15 to 50% of our adults, which is really a frightening statistic here, more than 100 million Americans. And we know that from really good national research that has been done. It can result from incurable disorders. It can be an incurable nervous system disorder, but it may have been a curable condition that was just not adequately treated. For example, up to 50% of post-op patients and post-trauma patients will have pain at a year when their injuries themselves actually had healed far earlier. Persistent pain accounts for 40 million outpatient visits. So talk about healthcare costs. And persistent pain is the #2 reason for hospitalization. It costs us billions and billions and billions of dollars per year in health and disability costs. Look at our Medicare expenses, over 100 billion per year for our Medicare recipients. Reduces health longevity and our quality of life as individuals and as society. Causes degeneration of regions of the brain, resulting in significant impacts to patients and their families, and again, their community and society. Results in lost income and reduced productivity, impacting all of us, and results in loss of retirement savings for many people. So that concludes this module, but we're going to have a little time now to go over some possible test questions that you might be exposed to. So Mary, come back so we can see you.
I'm here.
Okie dokie.
All righty. So let me ask you some of these sample test questions, Maureen.
Okay,
So
I
nerve
gotta
fibers
prove
that
that
are
I was listening to
unmyelinated,
you.
thin, slowly transmitting, transmit dull, aching, visceral pain that is diffuse in nature. What
Okay.
kind of fibers?
Okay, so I was listening to your part of the lecture. So I do remember that the A delta and the C fibers are the 2 different types of pain fibers. And A, because I rely on memorization clues, A comes before C. A is the first letter in the alphabet, so A is the first type of pain fiber. So C is going to be the slower one. It's unmyelinated thin. Yep, I'm going to go with C being unmyelinated thin and slower transmitting. Beta fibers, I know, come from touch and temperature, so they wouldn't have anything to do with pain. And mu are not fibers. Mu are receptors in the central nervous system that opioids attach to. So what do you think?
I think you're correct in saying C.
Okay, good. There we go.
Great way to memorize.
Yeah. Okay, so there we have it.
The next one, which nerve fibers are responsible for what is known as first pain?
My little memorization cue. I'm going with A is the first letter, so A is the first pain, A delta.
And you are correct.
There we go. Okay, Mary, here's one for you. Which of the following is the correct sequence of events describing pain transmission?
So this was directly from what I spoke about with nociception, and nociception is transduction, transmission, perception, and modulation in that order. So it has to be C.
And let's see. And there, Mary, you are so smart. You got it right. Okay. I'm going to ask you this one because you did this one. Many theories regarding pain exist. Which of the following has resulted in the most innovative treatments in the past 50 years?
Well, this one is kind of simple if you think about it. We talked about all A, B, C, and D, but the one that has really been the most widely accepted, probably one of the most current ones that has created from its it's the gate control theory, looking at the gate control theory and how the nervous system works to transmit pain and stop pain with a neural gating mechanism has created a lot of our current treatments that we use all the time for pain. You know, the one I keep going to is epidural steroid injections. It definitely helps close the gate in the descending track of the spinal cord. So it has to be the one that has created the most innovative treatments is the gate control theory.
Yeah, I like that. And you are correct. The gate control theory it is.
So let me ask you this. Pain that is an abnormal processing in the central or peripheral nervous systems, producing pain that serves no purpose at all and is very difficult to treat.
And there's only one possible answer here, and that is going to be neuropathic pain. Neuropathic pain is always abnormal processing, and it can be central or peripheral.
I agree with you.
I just would add on that, neuropathic pain is usually what's responsible for chronic pain. But the answer is neuropathic because that's the primary cause.
Right.
There we go.
Excellent. I'll ask you this one too, Maureen. Cardiovascular effects due to unrelieved pain may include.
So to answer this, I need to know that pain causes the sympathetic nervous system to go into high function, the
Right.
fight or flight response. And when I fight or when I flee, I have an increase in heart rate, my blood pressure goes up, and I'm hypercoagulable. So I am going with C.
I agree with you.
There we go. Mary, this one is yours. Regarding pain physiology, the transfer of energy from one form to another.
So these four answers are the four distinct steps of nociception, but the first step is the transfer of that energy, that thermal or chemical energy into a nerve stimulus in the body is the first phase of four, and that is a transduction.
So one of the ways, again, me with my little memorization things that I have to use. So a transducer, I worked in the ICUs for a long time. We had transducers that actually would take a mechanical signal, like the pressure coming out of somebody's artery, would go onto the transducer, and the transducer would take this mechanical signal and change it into an electrical signal so you could see it on the monitor. So it would change the energy from one form to another. So that's what helps me remember that with pain.
It's a great way to remember it.
Okay, so for the science of pain, I'm going to let you do the bullets, Mary. For the science of pain, remember.
These are the important things. Don't forget that uncontrolled pain has significant consequences on the human body. Pain involves those four processes. Don't forget your nociception: transduction, transmission, perception, and modulation. Pain may be nociceptive, neuropathic, or mixed. Someone could have both nociceptive and neuropathic pain going on at the same time. And gate control theory is the most widely accepted theory and the most treatment influencing theory of pain. So many treatments have come out of the gate control theory.
Great. So that concludes our presentation. You have references here for you to do a deeper dive on the material that we've presented today. And I wish you the very best of luck on your exam and certainly in your careers. And I Wish you all the best in managing your patients with pain.